remember why this question was asked? I asked this question, no?
Yes, sir.
Last week's case was the bladder tumor, isn't it? This question has to be now sorted out. Okay, go ahead.
Sir, ureteric frozen section in radical cystectomy.
Sir, madam has come.
Okay.
Good morning, sir. Sorry, was late.
No problem. We also finished rounds and came this time.
Okay.
Yep, carry on.
Ureteric frozen section analysis at the time of radical cystectomy for urothelial cancer was introduced to identify and excise all potentially malignant tissue and reduce the risk of local recurrence.
Excuse me, slides are not moving. Only first slide we see that heading.
Okay. How it is?
Yeah.
Keep it on the, don't keep it on the PowerPoint mode. But somehow it doesn't move.
Ureteric frozen section analysis at the time of radical cystectomy for urothelial cancer was introduced to identify and excise all potentially malignant tissue and reduce the risk of local recurrence. The incidence of urethral and the ureteral recurrence after the radical cystectomy ranges from 1 to 8% and from 4 to 10% respectively. Although the specificity of frozen section was ureteral and the urethral margins ranges from 83 to 100% across the studies, sensitivity ranges from 69 to 93%. Clinical significance of positive urethral and the ureteral margin is unclear. There is a low risk of recurrence of ureteral or the urethral margins, even the surgical margins are positive for malignancy. In the most studies, the rate of positive margins are far greater than the ureteral recurrence. The result of frozen section does not seem to be affect the disease-free or the overall survival. In the frozen section, at a higher magnification, there is a misinterpretation of a benign nuclear ATP as a malignant. The American Urological Association guidelines recommend intraoperative verification of negative urethral margin using the frozen section analysis before offering an orthotopic urinary diversion, especially in the patients with risk factors of urethral recurrence. While the current European Association of Urology guidelines have not provided any recommendations regarding the role of intraoperative frozen section analysis, its potential usefulness is discussed only in the men undergoing radical cystoprostectomy who harbor carcinoma in situ or the extension of the tumor in the prostatic urethra.
Don't confuse urethra with ureter.
Yes,
We are asking about ureter.
Ureter.
You are commenting more on urethra also. So that's a different topic altogether. Anyway.
Neither of these guidelines made any recommendations regarding a frozen section analysis of ureteral margins. Thereby, there is no clear evidence on the necessity of performing frozen section analysis during the radical cystectomy. I quoted to few studies. Utility and the significance of ureteric frozen section analysis during the radical cystectomy, which was published in the DJUs. The practice of frozen section analysis of the distal ureters at the time of radical cystectomy has remained constant at the University of Southern California since the early 1970s. In the present study, they started to address the operating characteristics of frozen section analysis as a diagnostic test and ultimately the association between the adverse frozen section analysis pathology and the risk of UTUC, local recurrence, and the overall survival. This study includes 2,047 patients underwent radical cystectomy for the urothelial cancer of bladder with intraoperative frozen section analysis of ureters between 1971 to 2009. The conclusion of this study is the present data call into the question the utility of routine frozen section analysis of distal ureteric margin at the time of radical cystectomy. Routine frozen section analysis of distal ureteric margin has a poor sensitivity, which is marginally improved in the patient with pre-existing CIS. The predictive utility for the upper tract recurrences is questionable, and the permanent ureteric margins of the proximal resection may be sufficient to predict the potential upper tract recurrence and guide the risk-adapted surveillance. The process of sequential sectioning may remain valuable in preventing the anastomotic recurrence and requires prospective evaluations. And another study is accuracy of frozen section analysis of urethral and the ureteral margins during radical cystectomy for the bladder cancer. It is a systematic review and a diagnostic meta-analysis. The 14 studies comprising 8,208 patients were included in this quantitative synthesis. The forest plot revealed that pooled sensitivity and the specificity for the frozen section analysis for the urethral margins during radical cystectomy were 0.83 and 0.95 respectively. While for the frozen section analysis of ureteral margins, the pooled sensitivity and specificity were 0.77 and 0.97 respectively. The calculated diagnostic odds ratio indicated high frozen section analysis effectiveness and patients with positive urethral or the ureteral margins at a final pathology are over 100 times more likely to have a positive frozen section analysis than the patients without margin involvement at final pathology. The conclusion of this study is intraoperative frozen section analysis demonstrated high diagnostic performance in detecting both urethral and the ureteral malignant involvement at the time of radical cystectomy for the bladder cancer. The frozen section analysis of both urethral and the ureteral margin during radical cystectomy is accurate enough to be of great value in the routine management of bladder cancer patients treated with radical cystectomy. While its specificity was great to guide the intraoperative decision making, its sensitivity remains suboptimal yet. These are the two studies.
So this is a meta-analysis.
Sure.
And like many meta-analysis, it has provided some information,
Sure.
but not something that we all say, okay, leave it alone. He is not saying stop it.
Sure.
He is not saying don't stop doing it. Yeah, do it because it is specific. If it says cancer, it's cancer. So it's like one of those things that happen in surgery, no? If you look at the University of Southern California, 1970, they started doing it. Now you think back in 1970, who are all the people there in University of Southern California? You will realize that a guy called Donald Skinner was there. He was one of the leading oncosurgeons in the world. Okay, a lot of neobladders, this and everything. These guys, for radical cystectomy, huge volume of data. And he would have decided in this, because he was a senior guy at that time itself. So they would have done all this. They didn't have access to many of the newer things that we had. And they wanted to be sure, because this was a routine practice in the radical cystectomy. This was a routine practice. Before the anastomosis, ureteroileal anastomosis was done, they would take it, wait for the frozen section, guys will unscrub, go and have a coffee, and then only come back and then only proceed. This was the standard. Then somebody else came along and decided, isn't this a waste of time? Is it necessary? So they took out all the data to decide. It's like many things happen in surgery when there's a change of guard. I'll tell you a very simple thing that happened in Vellore. All the donors were getting heparin. All the donors, live donors, were getting one shot of 5,000 units of heparin before the artery was clamped and the kidney was removed. After some time, we said, this is a dangerous drug. The donor should have nothing done to him except the nephrectomy. The least amount of drugs, the least amount of morbidity for a nephrectomy for this fellow. So we stopped putting heparin for the patient. So no more heparin, just finished. It didn't make any difference at all. Whether you gave heparin or didn't give heparin, the outcome was the same. So no heparin was used. Antibiotic was a routine. You stopped using it. One dose of antibiotic, that's all on the table. And that is it. No more antibiotics for the recipient. Even till today, there's no antibiotic for the recipient. People will not believe it, but that's how it is. So, some things in surgery are ingrained, and then a new guard comes and you want to change it. Take it, change it, see what happens. You begin to question some of the philosophies. My surgery boss told me you will not give blood more than 3 days old. Something like that. You must give, because urea will go up. You can't give blood transfusions when the blood urea is high. All these things. So, everybody trained at that time under difficult circumstances, and they have decided that this is what it is. Now, it is rectourethral fistula. I am paranoid about it. And I will not change my practice. You may come and change it, that's your call, but I will not change my practice. Simply because over the years I've seen so many failures, all coming back here, there, so many. And I've devised one protocol for this, that's all. This is how it will be. You can do it whatever you want, that's your call. But if I am handling the patient, this is my protocol. That's a problem with surgery. For everything, you cannot have a randomized controlled trial. It's not possible. So you come and somebody at a meeting, somebody said, yeah, go ahead, you do it that way. I'm not going to fight with you. This is how I do it. You ask me how I do it, this is how I do it. Isn't it excessive keeping a patient on colostomy for such a long time? Yes, it is excessive. He is willing for it. Why are you worried about it? If your patient is bothered about the colostomy, you go and close it. But every failure of fistula, you will see the colostomy has been closed. Every failure. When you look at all the patients where it is premature closure of the colostomy before you tackle this. Every one of them. So that's the problem. Especially with, you have to make sure that the urethra is perfect before you do anything. One patient told me, sir, I had enough of this. Do you really want me to close the colostomy? He said, it's your call. He said, I'm very comfortable. For so many years, I've had trouble. I'm passing urine very well. This colostomy is doing me very good. I've got this, he had this imperforate anus. I said, I don't have to struggle to pass motions because my lower end of the rectum is fine. This is okay, I can wash it every day and I put a small pad, I am fine with it. So do you really think? I said, it's your call. You want to close it, you close it. So it's that way, you know. So surgery, frozen section, routine analysis, all this is part of the story. So now we stop doing it. Let me ask you one question, Dhanush. What is the best operation for TCC? To prevent any recurrence, this, that. TCC in general. I'm saying urothelial cancer. What is the best option in the patient to prevent him from getting the disease? You caught it early, you're sure there is no other cell anywhere but this. What is the best operation? Huh? What's the really best operation?
TCC bone.
Urothelial cancer.
Urothelial cancer. Of the bladder.
Urothelial cancer of the human body.
Of the human body.
Where else will you get? I'm talking of bladder. Bladder is the most commonest, no?
Now it's a new adjoint.
See,
Sir, can I come in, sir?
if you do cystectomy,
Ganesh,
you
sir?
can get recurrence in the upper tract. You do nephrostomy, you can get recurrence in this. So the best operation, take everything out. Take out the bladder, take out the kidneys, take out all urothelial lining tract, right up to that urethra. And that's what we do when we have to have a transplant in a patient who has to have nephrotic for urothelial cancer. It's very unusual. So we have done. Ablate the entire urinary tract because you can get with the immunosuppression, so will get somewhere. And it is known that urothelial cancers can occur in the allograft. So if somebody already has gone into renal failure because of this, then nephrorectomy and this cystectomy. So that the problem is you cannot live like that, no? And because the risks are low, suppose the risk of upper tract urothelial cancer was more than 50% with bladder cancer. Life would have changed completely, isn't it? As it is a dirty disease. Tell me which part of the world this is very common. Left side, right side, upper tract, lower tract. Which part of the world is it very common? But not that bad. There's always a balance. There's always, God has given a balance. Which one?
Balkan is not in China.
Oh, but they grow.
I can't hear you.
No, we were also discussing the same. Adar is saying something about China, so I was.
China, no man, China got red meat and all that. That is different. We are talking of this upper tract, this urothelial cancer. Which part of the world is it so common? You get right side, left side, recurrent, you take out one, again the fellow comes, you take out bladder, keeps coming.
Egypt and Balkan
states. Now, not which are the Balkan states. They're not the Mediterranean states. Okay, Mediterranean is different to Balkan, and there's a reason for it.
And also Egypt's schistosomiasis, they have a lot of CF.
That is squamous carcinoma. That is squamous carcinoma. They won't get TCC. So there's a reason for why the Balkan states have a higher rate of upper tract TCCs. But as Bobby said, they are of a much lower grade, and therefore conservative treatment can be employed for them because of the high rate. So you must find out why. There's also reason for it. Okay.
Balkan nephropathy is a predisposer of TCC or not?
Is analgesic nephropathy predisposing factor for TCC? No, huh? You are shaking your head this way, I don't know what it means. He said no. This nodding of the head. Huh? You go to England and America and you nod your head, they will get zapped. No, you are Indian only. This nodding of the head is very Indian. Yes or no? That's all. Analgesic nephropathy with analgesic abuse.
Yeah.
Which country was it has been reported the highest rate? Australia, man. Very high rate of analgesic nephropathy. Pumping in these medications. Huh? They've also calculated how much of analgesic you need for how many years to give you this TCC. That also is there. So there are some predisposing conditions for upper tract urological malignancy, right? Apart from smoking and all this. If you look at the nephrology books, book by De Wardner, or even if you look at Bernard, they will tell you how many years you need to take analgesics and the total consumption of so many grams of phenacetin.
So you think it is 10 to 12 kgs for more than 10 years?
Yes. I thought you will give them time to go and look up. You are giving the answer to it. Anyway.
Our case presentation is also
Right. Start. Absolutely, I'm happy.